Hello and welcome. Thank you for attending our mini symposium, which will explore health, gender, and indigeneity among American Indian, Alaska Native, Two-Spirit, Indigiqueer, transgender, and gender expansive persons. Next slide, please. The speakers here are a collective of researchers, educators, behavioral health providers, medical providers, advocates, and faculty experts for the Transgender and Gender Affirming Care ECHO program at Northwest Portland Area Indian Health Board. Please check out our bios on the WPATH website for more information on all of our incredible speakers joining us today. Next slide. We're also a coalition of partners in this work and would like to acknowledge a non-comprehensive list of all of our exceptional colleagues. For space reasons, we're not able to include everyone's pronouns, titles, or associations here, but if you're interested, we certainly encourage you to seek those out. Next slide, please. We'd like to make a note that the opinions in this mini symposia are our own unless otherwise stated. Next slide. We name the ground beneath our feet in Montreal as the homeland of Haudenosaunee, Kanien'kehá:ka, and Anishinaabe. Since some of us will be joining virtually outside of this common physical space, we also invite you after the session to learn where you are today and hereafter. You are on native land. Next slide. By way of a presentation and panel discussion, we'll share about intersectionality as paramount to American Indian and Alaska Native, Two-Spirit, and transgender and gender diverse people's safety and gender affirmation in healthcare settings. The learning objectives of the session are listed on the WPATH conference platform website, where you may review them in detail. We'll employ the terms American Indian and Alaska Native to refer to persons from or connected to Indian country. Alternative terms will include Indigenous, Native American, and Native. The term American Indian and Alaskan Native also carry specific political legal significance in defining persons who are enrolled members of the 574 federally recognized tribes in the United States, and therefore are endowed with specific legal rights to health care through the Indian Health Services, which is a federal agency of the United States government. Finally, we'll use multifold terms to describe gender diversity beyond the normative colonial frameworks of male and female binaries. We'll use the abbreviation AI/AN to S-TGD in this text of this presentation. And at this point, I'd like to invite in our first speaker, Tavi Han.
So what is Indian country? What does that mean? Generally speaking, it's all native places and spaces across the United States and includes close to 600 tribal nations that occupy these spaces. It's wherever you find indigenous pride, communities, and ancestral homelands. It's in urban and rural places, and it exists whether or not it's acknowledged in history and textbooks. Legally speaking, Indian country with a lowercase c is found in US policies and Supreme Court rulings in reference to federal relationship with American Indian, Alaska Native land and people. What is ITU healthcare? The Indian Health Service is a part of the federal government's responsibility based on constitutional and treaty rights to deliver healthcare to American Indians and Alaska Natives and provides funds for tribal and urban Indian health programs. The Indian Health Service, or you'll hear us say IHS, is part of the federal government's responsibility. It's part of the Department of Health and Human Services, and it serves at least 2.6 million Native peoples. Tribal contracts or compact health centers, and you might also hear us reference 638 compacts. They're operated by tribes and tribal organizations, and urban Indian health centers are outpatient healthcare programs and facilities serving American Indians, Alaska Natives, Indigenous folks living in urban areas. The Urban Indian Health Program, UIHP, consists of 41 nonprofit 501c3 programs nationwide. The programs are funded through grants and contracts from IHS. They're operated under the Indian Self-Determination Act. Next slide, please. And this slide is a map where you can see where different Indian health facilities are located. Next slide, please. What is Two-Spirit or Indigiqueer? The term Two-Spirit came about in 1990 at a Native LGBTQ+ gathering, where people wanted a term that didn't come from colonizers and could be used across tribes. Today, the terms Two-Spirit or Indigiqueer are used by many Indigenous people, whether traditional or not, as a rejection of Western understandings of sexuality and gender. Next slide, please. We have some data about how Two-Spirit and Indigiqueer people today are describing their identities. And this comes from the Pride Community Connectedness and Healthcare Access Survey done in 2020 with the Paths Remembered project, which Itai is going to talk a little bit more about. But some of the findings there were that 79% of all trans and gender diverse respondents identify with at least one non-binary term when describing their gender identities, such as non-binary, agender, transgender, genderqueer, gender fluid, Two-Spirit. And then when we look at the youth measures, ages 15 to 25 respondents, 52% report gender identities that do not include binary terms like trans woman, trans man, woman, or man. 92% describe their gender identity using at least one non-binary term, like non-binary, agender, transgender, genderqueer, gender fluid, Two-Spirit. And then 63% use Two-Spirit to describe their gender identity, whether just by itself or in combination with other terms. And so one important point we want folks to take away from this is that Two-Spirits and Indigiqueer people have been here, are still here. And today, most are not experiencing or describing identity as either man or woman, or just feminine or just masculine. And some further findings from the qualitative data. None of the respondents who used terms like Two-Spirit or Indigiqueer to describe their identity did so first to express an identity that wasn't cisgender. In fact, it's described as the culmination of self-acceptance, cultural pride, and decolonization. A lot of times we hear the term Two-Spirit applied alongside more Western terms to describe gender identity, like non-binary and binary terms. But none of the respondents described Two-Spirit in binary ways, and it seems to be thought of as a separate, distinct identity from Western terminology. In fact, one 28-year-old respondent in the qualitative subsample identifies as a cisgender man in the English way, but holds a separate Two-Spirit identity that they don't feel is binary at all, and it's important for them to fully express and embody that as part of their own healing. Next slide, please. This is a ledger drawing, and it's depicting Cheyenne Ehe'iman in a victory dance that was held after Custer's defeat in 1876. The scout dances, the tribe's most important ceremony, were managed by the Two-Spirit Bare Leg Society. The society was small, but also had roles such as medics and healers in battle. And a side note is that colonizers viewed those roles as weak, whereas the tribe viewed them as highly important special roles. And the society also hosted social dances so that young people could find a love match. And this is just one example that we have from one tribe. Next slide, please. The US government had a policy to force assimilation. And the quote here and the statement here is referencing the specific policy that was created and put forward. But it's important to know that boarding schools have existed since the 1700s. A lot of Christian denominations participated in this with mission boarding schools, where they believed that through civilizing Native children, they were saving our souls. Some children were forcibly removed from families and sent to the schools. And then other times families were told, if your child comes to this school, they'll be able to learn English and they'll be better positioned to be able to deal with white people. Residential school survivors have told consistent stories of extreme physical and emotional abuse. The kids were taught to be ashamed of being Native. Two-Spirits had to go into hiding and try to blend in to avoid even worse punishment. An elder, Judy Tallwing, has shared some of her stories with me of her residential school experience. And she said that she was targeted by nuns in the school for being a lesbian, but she didn't even know what that word meant. She had never heard it before. She was mistreated for being Two-Spirit and Indian and put in solitary confinement as a child. So when we hear these things, can we understand how this has led to a lot of our people over generations internalizing the messages that Two-Spirits and indigenous queer people are shameful and dirty? And that's just one after effect of forced assimilation. Next slide, please. European colonizers were distressed when they encountered Two-Spirit peoples. They experienced Two-Spirits as evil and unholy in European heteropatriarchal cultures. In order to be successful in taking land, the colonizers had to remove the fluid gender structure of some indigenous communities, as well as removing women from centric positions. They wanted to instill the heteropatriarchal ideals into communities. Some indigenous communities conformed to the ideals in order to survive, or simply hid traditional practices and refused to answer questions about traditional practices and knowledge. Two-Spirit roles in particular were singled out for condemnation, interference, and a lot of times violence. As a result, Two-Spirit traditions and practices went underground and became protected knowledge, or sometimes disappeared in tribes. As homophobic European Christian influences increased among natives, respect for indigenous queer people declined in correlation to the influence of those belief systems. Two-Spirit people have often been forced, either by government officials, Christian missionaries, or their own communities sometimes, to conform to standard gender roles or presentations. And some who couldn't conform have gone underground or even died by suicide. Next slide, please. So this is the legacy. And then some of the challenges that are faced today are disconnection from culture, cultural dissolution, and Andrew Jolivet calls it post-traumatic invasion syndrome. Pain, shame, stigma, isolation, invisibility and erasure in non-native spaces and communities, such as queer spaces, activist spaces, educational spaces. Not being able to hold traditional sacred roles in some communities and tribes. Colonized views of gender and sexuality within some tribal communities. Generational and ancestral trauma. Threats of violence and murder, experience of sexual assault, and lack of access to affirming and knowledgeable healthcare professionals. Some tribes have retained their original knowledge, like I mentioned, of Two-Spirits and the specific terms and specific roles within the tribes. And then a lot of tribes have lost the specific terms that were used. And I'll say not even lost, because I said they were really intentionally taken. And sometimes that knowledge may be held with certain people within tribal communities, but isn't widely known. And then some tribes, elders will say, we didn't have the terms, specific terms, because that wasn't, the identities weren't important in that way. We were just, placing importance around whether people and individuals were contributing to the good of the community. Next slide, please. This photo is of Charlie the Weaver in about 1895. Charlie was a Dene Two-Spirit whose dress was different than either male or female traditional dress and held roles such as being a weaver and a healer. A Two-Spirit elder once said to me, "We can do our best to learn our roles and responsibilities in our own tribes if we have access to that knowledge. And in the absence of that, we have to create new ceremony, new roles, new songs with our hearts in a good way. And that we have always been doing that." Next slide, please. This is a present day take on the first ledger drawing that I showed. This is by artist Ron Yazzie, who's Northern Cheyenne and Dene. And I want to really emphasize the point that Two-Spirit and Indigenous queer people today find ways to take care of each other in our communities, to create, to celebrate, to love, to heal, and to be joyful. Next slide, please. Today, Two-Spirits and Indigenous queer people of all ages come together for gatherings, sharing culture, stories, food, laughter. And this image is from last year's Montana Two-Spirit gathering and from the end of the week powwow. Next slide, please. Indigenous queer people experience joy and meaning. This photo is from the Indigenous Queer Joy Photo Project. Itai may be able to talk a little bit more about that project, but these photos were taken of Indigenous queer people around Turtle Island in places that bring that specific person joy. Next slide, please. And this is a photo from the Indigenous Queer Joy Festival held in Seattle this year. Next slide.
Okay, thank you so much, Tavi, and thank you, Jack, for getting us going. So I'm going to start out by also talking about the same study that Tavi mentioned, the Pride Community Connectedness and Healthcare Access Study. I'm going to talk about the phase 2, which was the qualitative follow-up, which was conducted in 2021 out of Northwest Portland Area Indian Health Board. We are one of the 12 tribal epidemiology centers in the United States. What we were really interested in from phase 1 that stood out to us was that 2S LGBTQ plus people, American Indian Alaska Native, queer and trans and gender diverse folks displayed extremely high levels of cultural pride and a lot of resiliencies as measured. And so we became very interested as well, having read a lot of the mainstream research that has come out since 2016, research that is largely white population focused, about the powerful effects of affirming trans and gender diverse folks in at least one social context, like school or home. When you do that, you see significant protective factor created by that affirmation. And that protective factor associated with that affirmation is connected to a whole host of improved health outcomes related to physical, behavioral, even social health. So that left us with the question about whether or not a very similar thing would be happening in the American Indian Alaska Native trans and gender diverse community. And what we wanted to understand as well is if so much of the pride that was being demonstrated within the community was pride in one's culture, in one's tribal background, then how does that influence or change the nature of that protective factor? So what we find is that while affirming the gender identities of trans and gender diverse folks in the wider US population has these positive health impacts, more meaningful in the American Indian Alaska Native 2S and trans and gender diverse population is being affirmed at the specific intersection of their gender and indigenous identities. we see a whole host of protective factors come out of that from the qualitative research. Those include not only some of the ones that we found in the mainstream research beginning in 2016, but pretty significant increases in self-esteem as described in the narratives of the respondents, but also increases in their ability to build community, which we know is also protective, increases in family health, because oftentimes the act of reclaiming culture is not an individual act, but a community and a family act. We saw protective political identities being formed and the likelihood of accessing care, which is something we'll talk about a little bit more. And this included the likelihood of accessing gender affirming care. So to reiterate what this means is that we did not see the same effects to affirming someone simply as queer or trans or gender diverse. But when they felt that they were uniquely seen as Indigenous and trans, or Indigenous and non-binary or gender diverse, that is when we start seeing the narrative shift toward these positive outcomes. So this is especially true as well when it involves the reclaiming of some of the roles that Tavi talked about that have existed since time immemorial. So when a person was validated and being seen as part of a legacy, a pre-colonial Indigenous history, that's a really powerful space to be in. Slide, please. This is one of the images from the Indigiqueer Joy campaign as well that Tavi mentioned. It's really powerful to us because also what we see is that when we talk to trans and gender diverse American Indian and Alaska Native folks, joy is something that comes up, and joy comes up in relationship to their narratives as it relates to a few different things. One is community. Joy is an outcome of being in community with other, not just other queer folks, but other Indigenous queer people. Joy is something that is experienced by having one's history validated, by coming to understand how that history impacts you and your own personal narrative. We also see that joy is associated with land and one's connection to land, not only tribal homelands, but the lands that one lives on. Joy is experienced as something that is connected to one's sovereignty, one's ability to self-govern, and this also relates to body sovereignty, having the ability to govern one's own body and make your own decisions in relationship to it. Joy is something that is experienced as it relates to cultural healing, which is connected directly to decolonization. Decolonization is discussed also as a mechanism for that affirmation, that whether in a community space, whether in a family space, or even sometimes just at the level of individual, when it comes to exploring these ways to exist as a queer person beyond Western meaning and Western concept, that decolonization has a healing effect. Slide, please. So when we also look at some of those comparisons between the mainstream research and that research with our American Indian Alaska Native folks, this is just a reiteration. The protective health effects for or experienced by American Indian Alaska Native, Two-Spirit, trans, and gender diverse people were not realized merely when accepted as genderqueer again, but when seen as uniquely existing at the inextricable intersection of genderqueerness and indigeneity. Now, this becomes really important because there's a lot of conversation about queer space, and specifically non-native queer spaces, which are largely shaped by the mainstream culture. And within those spaces, our respondents describe a lack of cultural relatability in those spaces, a feeling sometimes of rejection, a lot of experiences of racism and misunderstanding, and feelings of having to perform a certain type of queerness that does not resonate with their Indigenous sense of being. So all of this has becomes really important as well when we think about the spaces that we enter in order to access healthcare. So we'll see that on the next slide. At first, there's some quotes. I forgot. So 2 quotes from someone who was in the qualitative subsample from the larger study. Both of these come from Coyote, who was a 21-year-old Two-Spirit trans man. First, none of my identities really clash with each other in my mind, because my thinking is there have been many Indigenous people who are like me. This is a very common sentiment across the study, the power in understanding that our trans and gender diverse Indigenous relatives have been engaging with these practices and uplifted for these practices since time immemorial, for thousands of years. Also, I'm now doing the hard work that I couldn't have done before. I did the mental work of integrating my identity as a Two-Spirit person and recognizing that I didn't have to hate myself for all of my inadequacies. That is allowing me to take care of my body. I haven't been able to take care of my body for most of my life because I wasn't living inside of it. Now that I'm in a place mentally where I love myself and I want the best for myself, I'm able to go to the dentist. I haven't seen the dentist for 10 years until just a few months ago. We see respondents describe many experiences similar to this, whether they're talking about specifically avoiding or not going to a doctor, a physician, a dentist office. We see very similar thoughts around the ability to take care of oneself, the motivation to eat well, to exercise, to engage in community space. So this is the nature of the protective effects. And one thing I would like to add about the protective effects that we see as well that make our sample a little bit different from the mainstream population in that larger body of research is that when describing those positive health effects of being acknowledged as indigiqueer, we also see people talk about improvements in their cultural health and in their spiritual health. None of those are accounted for in the mainstream body of research. Next slide, please. So each of these things that we find in this data have some implications for the intersectional care of American and Alaska Native, Two-Spirit, trans, and gender diverse folks. Okay. So first of all, we need pathways for American Indian and Alaska Native, Two-Spirit, trans, and gender diverse healthcare professionals, okay? Because that sense of community is part of the way that people experience these positive protective effects of their identities. And so having a provider that belongs to your community or is like you, we think would be profoundly impactful in the lives of the folks we talk to. And also, we have to understand as well that much of the research is white-centric. And so it's really important as well to have someone in that system who can intervene and help to understand the cultural bridges there. Also, healthcare professionals, they need to have humility, cultural humility specifically. This is the ability to see yourself also as a learner in a care interaction, not just as the professional, not just as the person who is providing the care. Also, mainstream standards of care and best practices are limiting, and in particular, they're limited by Eurocentric allopathic models for care, wherein there's little room to account for community, for spiritual health, and for cultural health, all of which were named as deeply important and deeply tied to the way that our sample experiences health. We also know that there's a binary standard for accessing gender-affirming care that needs examination. And keep in mind, as Tavi pointed out from the same study, a large percentage of the folks who we talked to, both in the survey and that we talked to in the qualitative follow-up, experience gender in non-binary ways and find that more reflective of their original culture. And current access to gender affirming care actually requires those Western entry points. And so we need non-Western entry points to access things like insurance payment for gender affirming care, in particular medical and surgical procedures. Also, one thing to bring up is that when we talk about the behavioral health component, suicidality is oftentimes discussed as something that is irrational. As Billy Ray Belcourt, a Two-Spirit activist and author, points out as well, for many who experience poverty and overlapping oppression as well, suicidality is actually really sometimes a reflection of situations that are untenable and unlivable. And so we have to find a way to acknowledge the rationality and the desire, and also to meet people where they are. Lastly, as Tavi also mentioned, the US government has a federal responsibility to care for the health and wellness and provide, quote, high quality health care for American and Alaska Native people. And this is more than just a legal right, more than just a treaty right. This came in exchange for massive genocide, massive loss, and the largest loss of land base that potentially we've ever seen in human history. So with that, I will pass it over to our next speaker.
Thanks so much, Itai. So now we're switching gears and thinking about what we know from the research, what we know from sitting across from people, and how that plays out in our medical systems. And as Itai and Tavi both described, we can't treat gender identity and gender affirmation as this vanishing point where that's the only lens through which we view someone and their healthcare needs. We also have to recognize their connection to community, their spiritual health, and just think through how people define health in itself. And so we're really trying to push the message that intersectional care is good medicine. And as we go through the talk here, we'll think about what it means for folks having to go into these larger systems that have historically been the providers of more comprehensive gender affirming care, and what that sort of that impact that it has on people seeking care. The mainstream research has obviously well documented experiences of discrimination and fear, and when a system isn't responsive or aware or knowledgeable about individual care needs, especially as it relates to other intersecting identities, then we're really seeing the systems not meet the needs of our patients and communities. Next slide. So as we've said, good medicine recognizes that indigeneity is inseparable from Two-Spirit or indigiqueer identities. And we need to think about holistic healthcare and not just gender affirming healthcare without the other pieces of someone's experience and other layers of identity. So we really need to focus on caring for the whole person, finding out how that person defines health, wrapping in those cultural and spiritual health pieces that Itai highlighted, and recognizing that the systems that we have in place, that methods of care, healthcare systems that are built on Western or dominant cultural values, beliefs, practices, may not be effective or appropriate for American Indian and Alaska Natives, Two-Spirits, trans and gender diverse folks. Next slide. We talk a lot about environment as we think about healthcare as a whole and the need to be recognized and seen and reflected in our care environments. And this applies to both Indian health services and larger dominant health systems. And again, keeping in mind the importance of intersectionality and knowing that there has to be this recognition that there are Two-Spirit, gender diverse folks in Native communities, and that there are Native folks in these dominant health systems. This is just one example from an urban Indian IHS clinic. And this was put together by the youth in the clinic, and it's one of the first things that you see when you're coming in. In addition to environment, folks have to think about what they're representing as individual providers or staff in a clinic, and the importance of having Indigenous staff and available for folks, and hopefully sort of in the majority in these clinics, and are wearing pronoun buttons, are very visible for both their Indigenous roots as well as their gender expansiveness. For folks who are not Indigenous, it's important to have training available that recognizes the intersectionality and the importance of having that lens and care. And if we are having a clinic that prioritizes the needs of Indigenous and Two-Spirit folks, having larger visibility at these more more mainstream or dominant queer and trans events like pride parades and things like that is important, and organizers for those events need to recognize what it means to expand the table to make sure that all identities are represented. Next slide. Okay. And I've already mentioned a little bit of this, but in our dominant healthcare systems, if we do not already have Indigenous folks on staff, first of all, we might, and it just hasn't been a welcoming enough environment for folks to come forward and let people know that that is their experience. But when we don't have folks on staff, it's important to make sure that we're building relationships where folks are, and reaching out to community leaders, spiritual leaders, and American Indian and Alaska Native communities, and that those folks are also representative of gender diverse experiences as well. And there are often many regional resources that are available, as well as online resources. And in the resource lists that we give to folks, making sure that we're including resources that folks can access if they're looking to connect with Indigenous, Two-Spirit, and gender diverse populations and other peers. Trauma plays a big role in folks feeling a level of safety in healthcare environments, or even seeking healthcare to begin with. And it's important to remember that in addition to the well-documented experiences in mainstream research around historical trauma and gender-affirming care, that there's a long history of racism in medical care, and just the way that the gender binary was in some cases violently enforced by colonizers who now are often at the forefront of these medical systems. And so there's an impact on mind, body, and spirit. And again, as we're looking at holistic health, thinking about trauma from these different experiences and levels, so that we're not just addressing someone's psychological safety, that we're interacting with their body, with their spirit, and their spiritual health in ways that keep this lens in mind. And being mindful of stereotypes that and language that is often pervasive in larger healthcare systems, saying things like, we need to powwow about this, is one example that needs to be eliminated from our practices. And we might not even be aware of our biases, and therefore we need to be open to the feedback of our colleagues, our patients, the folks that we're caring for, so that we aren't perpetuating stereotypes on one hand, or erasing the history that folks are coming in with, and in workplaces and in healthcare environments. Next slide. And in our interpersonal interactions, it's important to think about what the norms are in medical systems. Who do we treat as the expert or the holder of knowledge? Does this line up with the way that Indigenous communities view the way decisions are made, who holds knowledge, how stories are told, etc. We also have to recognize that there is a long legacy of paternalism in healthcare, and this idea that we need to protect people from themselves and that they don't have expert knowledge in their life and their goals and what they need. And wherever possible, opening the doorway for really individualized and person-centered decisions. Here we are at the WPATH conference, and we are representing other professional bodies and academies. And it's important for us to know our history there as well, and that these standards of care are really built on Western medical ideals and enforcing for a long period of history, binary gender experiences. And when we think about surgical care, in some cases, we're kind of striving for the ideal, quote unquote, white aesthetic. And that might not be in alignment with the goals that folks in Indigenous communities are coming forward with. And even if something is written down in our practice guidelines, our professional guidelines and ethical codes, it's important for us to question where that comes from and push back when it is not in alignment with the needs of all the folks that we're working with or our own healthcare. And then as a white person, as a settler who provides this care, recognizing that there's historical power dynamics in our relationships, especially if we're in our larger health systems, and being willing to step aside and include the voices of our Indigenous colleagues and really elevate the importance of folks who represent multiple identities being at the forefront of discussions and care decisions. And we've referred to this several times so far, but it really is important to shift our mindset and rather than seeing a problem that needs to be solved, really listen to how someone is defining health. Maybe it is going to the dentist for the first time in 10 years. Maybe it's being able to go to a two-spirit gathering, and how as medical and behavioral health providers, we can be that bridge to resources that folks need, to connections that we're aware of, and that there might be generational differences in the way that folks define health, what resources they're interested in, and how they're going to approach interacting with care environment. And in particular for pediatrics, when we think of our sort of dominant model, there's the young person and at least one guardian, potentially two, in the room. In sort of the worst case scenario, the adults are all talking about the young person and their care without necessarily bringing in their voice. But as we're thinking about meeting the needs of Indigenous folks, being really mindful of who is valued in this young person's life. Is there a tribal elder that needs to be involved in the discussions? Is there a peer that could be at the table to be sort of a cultural translator, both between youth and adults and settler and Indigenous healthcare needs, and as just a couple of examples. It also means that we have to be mindful of what time means. And in typical healthcare systems, we get 20 to 30 minutes for return appointments. And if we're needing to involve the voices of multiple parties in order to arrive at a decision, that model doesn't necessarily fit having all those voices have their input and move towards a decision. Next slide. Okay, I will turn it over to Hannah.
Thank you, Jess. From here, with this vision of intersectional care in our minds, I want us to pivot to talking about Indian Country Echo as an incubator for intersectional care. And we'll start with a video.
In healthcare system. It spreads new medical knowledge throughout Indian country, from specialty care sites to the front lines of community care. Rather than information flowing in one direction, Indian Health Service, tribal and urban Indian healthcare workers learn from specialists, they learn from each other, and the specialists learn from Indian country as new best practices emerge. Through ECHO, IHS, tribal, and urban Indian healthcare workers use video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patients that otherwise they would have referred out to. Patients with chronic complex conditions get high-quality care where they live, from the clinicians they know. No waiting several months to see a specialist. No long drives back and forth to get critical care. ECHO exponentially increases access to specialty care by moving knowledge instead of moving patients. Suffering and pain are reduced. Lives are improved and even saved. And we strengthen the connection between Indian country clinics and communities. Let's do more for our people and system. Join Indian Country ECHO today.
So Indian Country Echo champions a trans and gender affirming care echo program, which coaches healthcare professionals to provide person-centered, culturally attuned care to genderqueer individuals in Indian country. Zoom-based echo sessions are open access to all healthcare professionals, whether connected to Indian country or not. And echo faculty include all of us here and our community members, educators, behavioral health providers, and medical providers. Since the launch of this trans and gender affirming care echo, participants have included behavioral health, medical and dental providers, social workers, community health workers, public health officers, and administrators, just to name some. Each hour-long echo session includes a 15-minute didactic on an intersectional care topic that's given by a faculty member or another community or healthcare-facing expert. Participants also bring forward consultative questions to the echo space in a 45-minute case discussion about the healthcare needs of the participants' real, though de-identified patients. Consultative questions consider gender-specific care needs of Indigenous and queer individuals across the lifespan. During case conversations, participants and faculty share knowledge and recommendations that contribute directly to case presenters' plans of care for their patients and with their patients. Since its launch in 2020, the Trans and Gender Affirming Care ECHO program has had 297 registrants. Annual 2020 and 2021 ECHO surveys demonstrate this program's contributions to promoting intersectional care, mentoring healthcare professionals in Indian country who themselves provide direct care to genderqueer individuals, and empowering ECHO participants as advocates for structural change and changes within Indigenous healthcare spaces. The map of the United States on the right shows the breadth of Indian country ECHO's impact based on the geographic distribution of participants who hail from 50 clinics and organizations across 18 states. Majority of these states overlying tribal nations are having urban Indian health programs. I want to share the responses of 3 participants from 2020 when asked about ECHO's impact. An area that expanded for me personally was understanding how to provide gender affirming care to individuals within Native community who also identify as Two-Spirit. Non-binary individuals or individuals that are transitioning, their identity is not the same as Two-Spirit. Learning about the cultural aspect of that was beneficial. Another participant said, "It's valuable to have someone with more clinical experience than me who does a lot of higher volume of this than I do. Because there's a difference between having information and having actual knowledge, that practice of the art of medicine." And then finally, another participant, "Everything you have done to connect me with people, even in my own healthcare facility, like me and another clinician." I'm like, "I didn't even know you existed." She's like, "I didn't know you existed. We both thought we were just these lonely islands within our healthcare facility trying to provide gender-affirming care. Among the many outcomes of this ECHO program have been the initiation of gender-affirming hormone therapies by ECHO participants and knowledge sharing with ECHO participants as they navigate providing affirming surgical and mental health services with their patients. Beyond Indian Country ECHO, the Northwest Portland Area Indian Health Board and Paths Remembered have built coalition across Indian Country to champion welcoming, equitable healthcare for genderqueer individuals. Their 2020 strategic plan identifies priority areas for gender-affirming care across IHS, tribal, and urban Indian clinics. This vision calls for collective and individual advocacy to steward a present and a future reality that is grounded in intersectional care. I welcome you to review the strategic plan after this presentation. And with that, I will hand back over to Jack.
Thank you so much, Hannah. And I wanted to say thank you to all of our incredible speakers that led us through today's session. And thank you to everyone joining us by watching this presentation, watching this recording that is part of WPATH's 2022 27th Scientific Symposium. Thank you all again and have a great day.